thank you so much for the opportunity to talk to you today about molecular testing in thyroid nodules and thyroid cancer. It's a great pleasure to be here, and I would like to thank the organizing committee for inviting me to give this talk. So I have nothing to disclose. And molecular testing, generally, we tend to think about it in the case of thyroid nodules with indeterminate cytology, but actually molecular testing is very useful at many stages in the management of thyroid nodules and thyroid cancer. So it is useful at the initial presentation when we have indeterminate cytology. It's helpful for prognostication and management decisions, and it is sometimes very critical in the choice of targeted therapy. And I will discuss most of those stages. I'm not going to spend time on genetic testing at the time presentation, but just to mention that molecular testing can disclose a genetic syndrome or genetic cause for thyroid cancer. However, again, for the sake of time, I'm not going to discuss this situation. But we are going to focus on the other three. Indeterminate cytology or Bethesda 3 and 4, molecular testing can be of crucial value to refine the diagnosis and also to help the clinician in deciding on the next step of management. And if surgery is decided, molecular testing can help decide what type of surgery and what is the subsequent management. And again, we'll discuss this in some details. So let's focus for the time being on this situation of indeterminate cytology. Now, we all know that thyroid nodules are very common, especially when we use ultrasound and other imaging techniques. This study or this compilation of studies put a long time ago by Dr. Mazafiri remain actually true today, in that thyroid nodules are increasing in incidence with the increasing age. You can see around 60 years of age, around 50% of the people who are tested by ultrasound, or in the case of autopsy, they will have thyroid nodules. So this is a huge healthcare issue, and we have to know how to handle it. Well, patient is obviously less sensitive than ultrasound, but again, the message from this slide is that thyroid nodules are very common. So we all know that fine needle aspiration plays a very important role in the diagnostic work of thyroid nodules. And when we do FNA, it's around 60 to 70% of the time we get benign cytology. And that's a very good situation because all that we need is to follow the patient. In about 5 to 10% of the cases, we will have malignant cytology. And again, that's easy to manage in the sense that patients usually would go ahead with the therapeutic thyroid surgery. But in around 20 to 30% of the time, we have indeterminate cytology, which we today call it Bethesda 3 and 4, and I'll discuss it in more situation. The recommendation around 10, 15 years ago is for this situation is to proceed with surgery because the risk of malignancy is not small. It's around 20 to 30%. And therefore, this is a risk that one cannot take, and patients will go for surgery. But it turns out that only 30% of those patients will have cancer and would be assumed to have the right treatment. But in 70% of the time, surgery was unneeded, as the histology will show benign features. So the question was raised around 15 years ago, can we use molecular testing to better filter out this indeterminate group and minimize unnecessary surgery? This is Bethesda system 2023, and it just basically lists the different categories that you are familiar with: Bethesda 1, 2, 3, 4, 5, 6. And this is the risk of malignancy, and this is the recommended management. So if it is non-diagnostic, the risk is still significant, and we should repeat the fine needle aspiration under ultrasound guidance. If it is Bethesda 2 benign, the risk is only around 4% on average, and you need to follow those patients. Again, it's important to note that you need to follow those patients. But the problem is with Bethesda 3, the ETB of indeterminate significance, with a risk of malignancy ranging between 13 to 30%, on average 22, and that's very significant. And the recommendation basically is to repeat FNA, or to do molecular testing, or to proceed with surgery, or to closely follow up the patient. Follicular neoplasm is even more, has a higher risk of malignancy, around 30% on average. And again, molecular testing or diagnostic lobectomy is recommended. In the case of Bethesda 5 and 6, the risk of malignancy is extremely high, and surgery is recommended. Molecular testing may be helpful in terms of deciding what surgery to do lobectomy or near total thyroidectomy. In Bethesda 6, the recommendation is again surgery, either lobectomy or near total thyroidectomy. So I think this is very good scheme. However, as you can see, the problem is these two categories, Bethesda 3 and Bethesda 4. So again, the question was raised a long time ago and led by Dr. Nikiforov from Pittsburgh, basically proposing that molecular testing can help us in this situation. So again, if we do FNA and send it for cytology, and it is benign, you can follow the patient. If it's malignant, you send the patient for surgery. And if it is indeterminate, Bethesda 3 or 4, you do mutational analysis or molecular testing. If it is positive, then the chance that this malignancy becomes significant and the patient should go for surgery. If it is negative, then the chance is becoming smaller for malignancy and bigger for benign histology, and the patient can be followed up. This is the history of molecular testing. It has gone through different evolutions. It started actually, again, with this proposal from Dr. Nikiforov, using only 7-gene panel, the BRAF, NRAS, KRAS, HRAS, RET-PTC1, RET-PTC3, BAX8, PPR gamma. So only 7-gene panel. And this was the beginning in 2009. Then in 2012, Firma came with gene expression classifier, which uses actually RNA instead of DNA here. And looking at the expression of around 167 gene, using microarray platform. At that time, next generation sequencing was not widely available, and they used microarray. Now, this test at that time had a very high negative predictive value, but there were issues with certain types of cancer, and it did not really stand the test of time. So it was changed later on, as we will see. In 2013, the first version of Thyroid, version 1, was introduced, and this is the first time we use next generation sequencing. And as you can see here, there are 12 genes that were tested, and again, after only 2 years, the gene panel was expanded with addition of additional gene and also fusion genes, and that's Thyroid version 2.1. And this was actually an excellent test with high positive and negative predictive value. Meanwhile, attempts to use microRNA was run by a company called Rosetta GX Reveal, and another company was also using microRNA, but was also adding somatic gene mutations, a SORA gene, and this was in 2016. Now, the revolution in all of this happened in 2018 with the introduction of Thyroid version 3 that we will discuss in more details, but it is next generation sequencing using 112 thyroid cancer-related genes And then Afirma gene expression classifier was completely changed in its approach, again using RNA transcriptome, but this time using next generation sequencing and expanding on several thousands of genes. And then Afirma added in 2019 and 2020 what is called Expression Atlas, where around 600 genes um, with 905 variants are reported, and also 235 fusions. And the last test that was developed further from these two tests here, the microRNA and the somatic gene mutational platform, is another test now called Thyroid Next Thyramir, or multiplex testing. And you can see this, this is a combination of next generation sequencing testing for several genes, around 11 genes, I think. And then if the test is not conclusive or just showing weak mutations, they proceed to microRNA using around 11 microRNAs. So this is the history of molecular testing starting 2009 to the current situation. Now, having said this, the three widely available testing is Afirma GSC, this one, with the expression atlas, and then ThyroSeq version 3, and ThyroNext gene Thyramir for the multiplex testing. As you can see from this slide, Afirma GSC looks at the expression profile using next generation sequencing for more than 10,000 genes. It looks also at genetic alteration of around 600 genes, including 905 variants and 235 fusions. And the result is reported as benign or suspicious. ThyroSeq version 3 uses DNA mainly, but also RNA-based next-generation sequencing. It looks at 112 genes with more than 12,000 variants and more than 150 fusion, but it also looks at copy number alteration and gene expression alteration. And the report comes as negative or currently negative or positive. Finally, gene next Thyramir testing uses also DNA and RNA-based next-generation sequencing, but also if the test is not very conclusive, they add microRNA evaluation. And the number of genes, 11 genes, 37 fusion, and 11 microRNA, and it's reported negative, moderate, or positive. Now, these are the initial or validation studies of the three tests. You can see Afirma GSC was evaluated in 191 nodules. The prevalence of malignancy is 24%. The sensitivity is quite high at 91%, negative predictive value 96%. These two features, the sensitivity and negative predictive value, are very, very important for rule out function of the test. So if they are high, more than 90%, the test has very excellent rule out power. And that's the case with Afirma GSC. The specificity and positive predictive value is less, with 68% and 47%. So it's not highly reliable rule-in test. It does not confirm the diagnosis, but it rules out the diagnosis of malignancy with high reliability, as you can see here. Now, the same situation actually for ThyroSeq version 3 at prevalence of malignancy of 28%, being tested in 257 nodules. It gave sensitivity of 94%, negative predictive value of 97%. So it is an excellent test to rule out malignancy. Its specificity and positive predictive value relatively better than Afirma GSC, but it still remains inadequate for confirming malignancy. And finally, ThyroNext gene Thyramir at a prevalence of 30%, tested in 178 nodules, has high sensitivity and negative predictive value, and also high specificity and positive predictive value. However, I must say those two tests, Afirma GSC and ThyroSeq version 3, were tested in multi-center studies with blind histology and cytology readings, and therefore they were well validated. Thyronex gene, Thyromere, has not been well validated. The study was retrospective, although the numbers are more impressive, but I would say the evidence is not as strong as it is for Afirma GSC and Thyroseq version 3. This is just another representation of the diagnostic parameters of these different genes. So you have Thyroseq version 3 in light green, you have Afirma GSC, and you have Thyrogene Next Thyromere, or the multiplex. And if you look at them, they are very comparable in their sensitivity, more than 90%. The same thing for their specificity, positive predictive value, and negative predictive value. Now, the most important here is that the negative predictive value is high and the sensitivity is high. So these diagnostic features are excellent for any rule-out test. There is another feature that is important, and it's called benign core rate. And benign core rate is the percentage of patients who can avoid surgery because of negative test. So if you look at Thyroseq, it has very good benign core rate of around 50 to 60% for Bethesda 4 and around 70 to 80% for Bethesda 3. Almost the same picture is seen here in Afirma GSC. So you can avoid surgery in around 60 to 80% of Bethesda 4 and Bethesda 3 respectively, using Afirma GSC or Thyroseq version 3. Real-world experience is important. This is a meta-analysis of Afirma and Thyroseq version 3, and they are giving more or less the same parameters. So in 7 studies here for Afirma GSC, it gave basically sensitivity of 94%, negative predictive value of 90%, again confirming its rule-out ability, and the specificity and positive predictive value is similar to the original studies. Again, Afirma GSC was analyzed in a meta-analysis of 7 studies with 472 nodules, and it is showing similar numbers. The same thing for Thyroseq version 3 with 530 nodules. Again, the sensitivity and negative predictive value exceed 90%. The specificity and positive predictive value is 50 and 70%. One of the questions that comes always, which test is better? And I have already shown you evidence that they are comparable, and I'm talking here about Afirma GSC and Thyroseq version 3 in the original studies and in their benign core rate and in their meta-analyses. Not only this is a randomized controlled trial that tested them head-to-head and showed actually no difference between the two. So this is Thyroseq version 3, this is Afirma GSC, and you can see there is no difference in sensitivity, specificity, positive or negative predictive value, whether you consider all nodule that came back as benign or negative as benign, or you just focus on patients who went on for surgery and had surgically confirmed histology. Again, you can see there is no difference between the two. This is a recent study from Canada, again, evaluating 2 things. This is a prospective study, actually, evaluating the value of Thyroseq version 3 and also assessing the cost effectiveness. And as you know, Canada is publicly funded health system. So it's important also to know what is the cost effectiveness. What you see here is 500 nodules prospectively studied between 2021 and 2023. Those nodules are Thyroid 3 or 4. The size is between 1 to 4 centimeters, and they all had Bethesda 3 or 4 cytology, and Thyroseq version 3 was done on these nodules. So out of the 500 nodules, 363 were negative and 137 were positive. you can see that positive nodule tended to happen in younger patients, 59 years versus 55 years. And also in Bethesda 3, more negative testing, Bethesda 4, more positive testing. So whether it's Bethesda 3 or 4 makes a difference. In Bethesda 4, you are more likely to get a positive test. Now, here again, a summary of Bethesda 3, 282, Bethesda 4, 218, so 500 nodules, positive in 137, which is 27%, and negative in 72.6%. That's the benign core rate. So around 73% of patients undergoing thyroid version 3 could avoid surgery. And here you can see actually 363 with negative testing were followed up. Only one patient underwent surgery and it was benign. So that speaks in favor of the test being reliable. On the other hand, here, 137 patients underwent were positive on thyroid version 3, and 35 of them underwent, all of them actually underwent surgery. 35 turn out to be benign. So you will still, positive test does not mean malignancy. Around 32% false positive rate. And malignancy was found only in 68%. The cost effectiveness, they calculated the cost effectiveness in a model, and what they found actually is per year there's a saving of around 860,000 Canadian dollar. So for the next 10 years, you will save around 6 million if you test 500 nodules using Thyroid version 3. For prognostication, this is, again, a big subject, but we're talking about type of surgery, use of radioactive iodine, frequency and intensity of follow-up based on molecular testing. Now, Nikiforov group looked at their experience of more than 50,000 nodule tested using Thyroid version 3. 65% were negative, 34% were positive. The benign core rate was 68%. Among the positive results, most of them were mutations, and 11% was gene fusion, and 11% were isolated copy number alteration. They classified this in low risk, intermediate risk, and high risk, and they found that low risk is very common in Bethesda 3 and 4, and high risk profile was very common in Bethesda 5 and 6. And using this scheme of low risk, intermediate risk, and high risk, you can see the mutation here. So RAS-like is low risk, and BRAF-like is intermediate risk. And if you have RAS-like or BRAF-like and any of these other mutations, TERT or TP53 or AKT1, BIK3CA, then it is high risk. Using this, you can see they studied around 600 cases, and they found very nice segregation of high-risk features with the molecular testing. So for example, high-risk papillary was much more in high molecular group, bilobar disease, gross extrathyroidal extension, vascular invasion, lymph node metastases, high grade, high TNM stages, high ATA risk stratification. They're all segregated very well in the intermediate and high risk group. In other words, this molecular classification is predict prognosis, predict histology, predict outcome also. Can see death happened essentially in all patients with in patients with high risk molecular group, and recurrence the same thing. Kaplan-Meier analysis is showing the same thing. This is the high risk group, this is the intermediate, this is the low risk, and you can see the segregation. Now, this was also tested in other scenarios that probably I will not have time to discuss them, but I want to go to the choice of targeted therapy. This is a summary of the current practice uh, in molecular testing for thyroid cancer. You can see in this algorithm in patients with anaplastic thyroid cancer, if they have BRAF mutation, the treatment is dabrafenib trametinib, or the dabrafenib trametinib plays a very important role in this. In medullary thyroid cancer, again, we are interested to see if there is red point mutation, because in that case, if the disease is inoperable or metastatic and progressive, we can use silpercatinib and pralsetinib. For differentiated thyroid cancer and poorly differentiated thyroid cancer, you can either use non-specific multikinase inhibitor like sorafenib, lymphatinib, cabozantinib, or you can do molecular testing. If it is negative, this is still your choice. If it is positive, depending on the mutation you find, you can choose your drug. So if it is BRAF, dabrafenib, trametinib, if NTRK, larotrectinib, entrectinib, and if it is red BTC fusion, silpercatinib, pralsetinib. I must skip some slides and go to the conclusion for the sake of time. So in conclusion, molecular testing is potentially important in different stages of thyroid cancer management. It may clarify the genetic basis of thyroid cancer. It has a well-established role in the diagnostic workup of indeterminate cytology, that is the 3 and 4. It has an evolving prognostic and decision-making role in thyroid cancer management based on molecular risk stratification. And in specific situation, it has a crucial role in the selection of targeted therapy, as I have shown you in that algorithm. Further studies are needed, especially for prognostic therapeutic values of molecular testing. A moment of celebration. My favorite team has recently won big champion, and I'm so happy about that. And with that, I stop here. Thank you so much.